All right, let's jump right into this explainer. Today we're doing some serious neurological mapping. We're going to explore the mind's vulnerabilities by systematically breaking down regional brain syndromes. Our goal today is to uncover exactly how specific, localized brain lesions actually manifest in patients, so you can build a complete, crystal clear picture of our neurological real estate without ever needing to go back and read the textbook.
We've got a fantastic, highly detailed roadmap for you today. We'll start with a broad overview of brain syndromes, dive deep into the anatomy and physiology of the parietal lobe, and then unpack unilateral parietal disease, dominant versus non-dominant syndromes, cortical sensory and Anton-Babinski syndromes, and finally, we'll wrap up the whole shebang with Foster-Kennedy syndrome.
Okay, kicking things off with Section 1, a quick foundational overview of brain syndromes.
So, the absolute core rule here is that destructive lesions in the brain predictably tie to very specific regions. Think about it like a map. If the occipital lobe takes a hit, it reliably produces homonymous hemianopia, which is a visual field loss on the same side of both eyes. Moving down to the cerebellum, location is literally everything. Lesions in the cerebellar hemispheres cause ataxia or a lack of coordination in the ipsilateral limbs, meaning the limbs on the exact same side as the injury. But if the lesion is right in the middle, in the cerebellar vermis, you'll see truncal ataxia, which affects the patient's core stability. In the brainstem, we typically get this very specific mix of cranial nerve deficits alongside long-tract findings. And if a lesion strikes the pineal region, it frequently triggers Parinod syndrome, heavily impacting eye movements. As you can see, everything is highly predictably localized.
But here's where it gets a bit tricky. The brain can actually mask its own injury sometimes. For example, a unilateral frontal lobe injury, meaning damage to just one side, might actually produce surprisingly few clinical findings unless the lesion gets massively large. The brain just kind of compensates. However, it saves the truly profound deficits for bilateral injuries. When both sides of the frontal lobe are damaged, you see severe apathy and abulia, which is essentially a total lack of will, drive, or initiative to do anything at all.
Now, moving all the way to the front, we have the prefrontal lobes. Think of this area as your brain's ultimate command center. It controls your executive function. This is the exact hardware that allows you to plan out your day, prioritize tasks, and organize your thoughts logically. But maybe more importantly, it's responsible for suppressing your raw impulses and actually understanding the long-term consequences of your actions. So when this specific area takes a hit, that critical executive filtering mechanism just completely breaks down.
All right, let's shift gears to Section 2 and meet the real star of today's explainer, the parietal lobe.
Geographically speaking, the parietal lobe is nestled right behind the central sulcus and sits neatly above the sylvian fissure. As you move toward the back of the brain, or posteriorly, it just seamlessly merges into the occipital lobe. Its inner medial border is defined by an imaginary line connecting the parieto-occipital sulcus straight down to the preoccipital notch. You really need to visualize this geography, because understanding exactly where this sits is key to understanding why the very specific sensory and processing deficits we are about to discuss actually happen.
What's really fascinating here is the massive division of labor between the two hemispheres. In about 97% of adults, the dominant side, which is usually the left side, handles highly complex language tasks. This means understanding spoken words and performing cross-modal matching, like seamlessly linking a sound you hear to an object you see, or a shape you see to an object you feel. The non-dominant side, typically the right, is the master of your body's spatial and visual orientation in the physical world. It integrates what you see with proprioception, which is your body's innate sense of where it is in space, allowing you to manipulate objects and perform complex constructional activities.
Moving right along to Section 3. So what exactly happens when just one side of this parietal lobe gets diseased?
Let's break this down point by point so you have this totally mastered. First up is anosognosia. This is a fascinating and, honestly, a deeply heartbreaking deficit. The patient becomes completely indifferent to or entirely unaware of their own clinical deficits. In really severe cases, a patient might literally look right at their own paralyzed arm or leg and completely deny that it belongs to them. They genuinely do not recognize their own impairment.
Next is allocharia, which is this totally bizarre sensory miswiring. Imagine you apply a physical stimulus, like a light touch or a sharp pinprick, to one side of the patient's body. Instead of feeling it there, their brain crosses the wires, and they actually perceive that exact sensation on the completely opposite side of their body.
Then there's dressing apraxia. You've got to understand this isn't just simple muscle weakness. It is a profound neurological neglect of one entire side of the body and its surrounding visual space. It specifically manifests when the patient is trying to perform routine tasks like putting on clothes or grooming themselves. A patient might only shave half of their face or put a shirt on just one arm, completely ignoring the existence of their other side.
And to wrap up this rapid-fire section on unilateral disease, we have sensory extinction. Here's how it works. If you touch the patient just on their affected side, they can feel it perfectly fine. But if you present competing simultaneous stimuli, meaning you touch both their left and right sides at the exact same time, the patient's brain gets overwhelmed. It will entirely drop or ignore the sensation on the affected side, and they will only report feeling the touch on their healthy side.
Okay, let's pull back just a bit for Section 4 and look at the broader dominant versus non-dominant syndromes.
A dominant, usually left-sided lesion is going to devastate language, causing various types of aphasias. It also commonly causes bilateral ideomotor apraxia. This means the patient absolutely cannot carry out verbal commands for physical activities, even though they can still perform those exact same activities spontaneously when they aren't thinking about it. You might also see tactile agnosia, an inability to recognize objects just by touch. Conversely, a non-dominant right-sided lesion strips away topographic memory. The patient literally loses their spatial sense of their surroundings and gets lost easily. This is also where you see that severe anosognosia and dressing apraxia we just talked about.
Now, if we are talking dominant lobe lesions, the absolute must-know condition is Gerstmann syndrome. Named after neurologist Joseph Gerstmann, this syndrome is an incredible localizing tool because it maps perfectly to the angular and supramarginal gyrus of the dominant hemisphere. For those of you keeping track of the specific Brodmann areas, we are talking directly about areas 39 and 40.
You definitely want to lock this classic tetrad into your memory, because Gerstmann syndrome always presents with these 4 distinct signs. First, agraphia without alexia. This means patients completely lose the ability to write, but surprisingly, they perfectly retain the ability to read. Second, severe left-right confusion. Third is digit agnosia, which is a highly specific inability to identify or name their own fingers. And fourth, acalculia, meaning they develop a sudden, severe inability to do basic math. If you see these 4 unique symptoms grouped together, you know exactly where to look on that brain scan.
Moving right along to Section 5, let's look at 2 highly specific conditions, cortical sensory and Anton Babinski syndromes.
Cortical sensory syndrome is directly caused by a destructive lesion in the postcentral gyrus. It becomes incredibly prominent when the lesion hits the specific area of the cortex that naturally maps to the human hand. Because the postcentral gyrus functions as the primary somasensory cortex, the deficits you see here are entirely sensory in nature, but as you'll see, they are highly selective. This creates a really fascinating paradox. While complex, interpretive sensory skills are lost, the basic raw sensations are completely preserved. Let's look at the deficits. Patients develop asterognosis, which is the inability to judge an object's size, shape, or identity just by holding it. They also suffer from agraphesthesia, meaning if you trace a number on the palm of their hand, they have no idea what it is. They also lose 2-point discrimination and their joint position sense. Yet despite all of that, their fundamental raw sensations like pain, basic touch, pressure, vibration, and temperature remain 100% intact.
Then we have Anton Babinski syndrome. This one is like a clinical illusion. It features unilateral asomatognosia, which again is that bizarre lack of recognition of one's own body parts. Now, clinically, this often seems far more common with non-dominant, right-sided parietal lesions. But why is that? Well, if the reality is, it probably occurs equally on both sides. But when it happens on the dominant left side, the patient usually develops severe aphasia at the same time. This loss of language completely masks their ability to tell anyone about the body awareness deficit, making it practically invisible to the clinician.
Finally, we've reached Section 6. For our final clinical mapping, we're jumping back to the frontal lobe to examine Foster-Kennedy syndrome.
Named after neurologist Robert Foster Kennedy, this syndrome is usually caused by a tumor, most commonly a meningioma, growing right in the olfactory groove or the medial sphenoid wing. It presents as a very distinct 3-step classic triad. Step 1, ipsilateral anosmia. This is just a complete loss of smell on the exact same side as the tumor because the mass is literally crushing the olfactory nerve. Step 2, ipsilateral central scotoma with optic atrophy. Basically, a blind spot develops right in the center of their vision on that same side due to direct pressure on the optic nerve. Step 3, contralateral papilledema.
This means the optic disc on the completely opposite side of the brain starts swelling up, driven by the overall elevated intracranial pressure from that growing mass. And occasionally, you might even see the eye bulging out on the tumor side if it invades the orbit.
But here's a thought to leave you with. Given that this tumor has to get absolutely massive and grow over a long period of time to cause these severe combined compressive and pressure effects, consider how modern technology has changed the game. Modern CT and MRI scans have totally revolutionized our diagnostic capabilities. Because we can catch these masses so much earlier now, before they grow out of control, this classic textbook presentation of Foster-Kennedy syndrome has become incredibly rare to actually spot in the wild today. It's a pretty amazing testament to how advancing technology literally changes the landscape of the clinical syndromes we see. Thanks for joining me on this deep dive into mapping the mind's vulnerabilities. Keep exploring, and I'll catch you next time.